Ladies and gentlemen, I'm going to start the proceedings. Thank you very much for coming. My name is Moira Stewart, and I'm Dr. Eng-Sing Lee's supervisor for his PhD. And it's Dr. Lee's day today. We have an audience here in the building at Western, and we have Dr. Fortin, who's one of Dr. Lee's advisors, and we have Dr. Burge, who's an examiner, who are joining us on a video link. So it's my happy task to introduce the candidate, Dr. Lee. So Dr. Lee currently is the senior consultant and assistant vice president of clinical services at the National Healthcare Group Polyclinics in Singapore. This is a group of 9 large clinics that cover half of the whole of Singapore. So Dr. Lee is a leader in primary care in Singapore, a clinical leader. His BSc and medical degree are from Aberdeen in Scotland in the mid-1990s. And then he worked in a variety of clinical jobs in the UK before returning to Singapore in 1999, where he became established as a general practitioner and a leader of clinical services. And so it's very interesting that a clinical operation, a massive clinical operation, would support research. And they have done so by encouraging Dr. Lee to come to London for his master's and then fast-tracking to his PhD, and making him currently the deputy head of the clinical research unit at the same organization. So I'm very happy to introduce him today to you and ask him to present the results of his PhD thesis. Thank you. Dr. Lee.
Thank you. Thank you, Dr. Stewart. Good afternoon, everyone. Thank you for coming here today to listen to a topic that I'm really passionate about. To be honest, I have no idea what the name of this topic was until I came to London 6 years ago. I met Dr. Moira Stewart, and she was the first person who mentioned this long word, multi-morbidity, to me. And now, 6 years later, I'm going to share with you the focus of my dissertation is on the measurements of multimorbidity. Before I start sharing my work, I would like to take this opportunity to thank and acknowledge all my benefactors that have helped me through this journey. The Singapore National Medical Research Council, my dissertation advisory committee, Dr. Moira Stewart, Dr. Bridget Ryan, Dr. Martin Fortin, Dr. Judy Brown, Mr. John Costello, Liz, Evelyn, National Healthcare Group, my clinical research unit, as well as Hougang Polyclinic. The World Health Organization defines multimorbidity as the co-occurrence of 2 or more chronic medical conditions in one person. The concept of multimorbidity was first published in 1976 and has been researched by many worldwide since the 1990s. However, the term comorbidity has been used interchangeably with the term multimorbidity for a long time, even up to now. Partly because of the different definitions used, the prevalence of multimorbidity varied widely in the literature and ranged from 12.9% to 95.1%. I will now clarify the difference between comorbidity and multimorbidity. Let's take Mrs. Tan for example. She suffers from depression, diabetes, osteoarthritis, and hypertension. She sees 4 different doctors for all these conditions. To the psychiatrist, he sees depression as an index condition. He treats diabetes, osteoarthritis, and hypertension as a by-the-way conditions he called comorbidities. To the endocrinologist, the index condition is diabetes, and all the 3 other conditions were comorbidities. To the orthopedic surgeon, the index condition is the osteoarthritis of the knees of Mrs. Tan, and all the other 3 conditions were comorbidities. But to me, as a family physician, there's no index condition. All conditions are just important. By considering the interactions of all the conditions and how they affect the patient as a person, we call the conditions multi-morbidity. Comorbidity is a concept that the specialists tend to use. Primary care physicians are advocates of the concept of multi-morbidity, where the identification of the index disease is neither obvious nor useful. From the patient's perspective, living with multimorbidity is a state of complexity affecting quality of life. From the perspective of the healthcare professional, most family physicians like myself struggle in applying clinical practice guidelines that are based on single diseases on patients like Mrs. Tan. From the health system's perspective, multimorbidity is associated with high levels of utilization across all resource types. I identified 3 gaps in multimorbidity research. The first gap is the definition of multimorbidity. There's currently no consensus on the following: the total number of conditions considered in the multimorbidity list, the type of conditions, the data sources of chronic conditions, the cut points used to define multimorbidity. Is it what WHO said, 2 or more conditions, or is it 3 or more conditions? And there's inconsistent description of the reference population in a lot of multimorbidity studies. The second gap is in the measurement of multimorbidity. Lefebvre and his team described 4 methods: simple count, grouping chronic diseases into dyads or triads, identifying homogeneous groups, or using weighted indices. However, the purpose of measuring multimorbidity was not explicitly mentioned. The third gap is the outcome measurement of multimorbidity. There are many out there, and there has been no consensus on which are truly the important ones for all the relevant stakeholders. Susan Smith and a panel of multimorbidity researchers recommended 17 core outcomes. The 3 essential outcomes from the list of 17 were quality of life, mental health, and mortality. I adopted 2 conceptual frameworks that were used to drive the research question, my thinking, as well as the interpretation of the results. The first is the patient-centered clinical methods. PCCM focuses on building a positive interaction between clinicians and patients, combining medical science with knowledge of patients as people, their experience, their values, and their beliefs within their context with an ongoing affirmative relationship. The second is minimally disruptive medicine, where a context-sensitive approach is used to provide care of patients that focuses on achieving patient goals for life and health while imposing the smallest possible burden on their lives. The 2 theories work in tandem at the personal, practice, and policy levels. I conducted 3 studies to address these issues in my dissertation. I will spend the rest of the session to describe the 3 studies in detail. The first study was the prevalence and common patterns of multimorbidity, which I will refer to as the prevalence study. The objectives of the study were to describe the epidemiology of chronic conditions using 2 lists. We chose the Chronic Disease Management Program, or the CDMP list, which is a list of 20 conditions whereby Singaporeans can enjoy subsidized health care if they are diagnosed with the condition, versus the Fontaine list, which is also another 20 conditions developed by Fontaine and his team after perusing many multimorbidity studies. The second objective was to determine the overall prevalence rate of multimorbidity based on the 2 lists and the 2 cut points. I refer to 2 or more conditions as MM2+, or 3 or more conditions as MM3+. The third objective was to determine whether there were differences in prevalence rates among the different age, gender, and ethnic groups. Finally, we described the common diets and triads of chronic conditions. The study was conducted in the polyclinics in Singapore. There are 18 polyclinics spread over the island of Singapore. Each polyclinic serves as a health center, providing government-funded subsidized primary care. On average, a polyclinic provides between 700 to 1,400 consultations per day. The 18 polyclinics are divided into 2 clusters: National Healthcare Group, where I'm from, and SingHealth. The study is conducted at the National Healthcare Group polyclinics, and they are located geographically in the central, western, and northern parts of Singapore. The study population was the total unique number of patients who had consulted a family physician. Data were collected from the electronic medical records. The denominator was all patients who had consulted a doctor at least once during the 1-year study period. The numerator was the number of patients with at least one doctor visit and at least 2 or 3 chronic conditions based on either the CDMP or the Fontaine list of conditions. The outcome variables were crude and standardized prevalence rates of multimorbidity. Diets and triads were created by summing every combination of 2 or 3 chronic conditions. There were 3 independent variables. Age was divided into 4 categories, gender was the usual 2, and ethnicity was divided into 4 categories: the Chinese, the Malay, the Indian, and others. We considered no overlap of the 95% confidence interval as statistically significant. We now move on to the results of the prevalence study. The total sample size was more than 780,000 patients. The number of conditions increased with age for both lists. The Chinese had the highest mean number of chronic conditions at 1.1 for the CDMP list, and the Indians had the highest mean number of chronic conditions at 1.2 for the Fontaine list. There were no difference in the mean number of conditions between the different genders for both lists. For objective 1, we listed the 2 lists side by side. There were no patients with psoriasis found from the study sample, reducing the CDMP list to 19 conditions. We removed chronic musculoskeletal condition from the Fontaine list because there were no primary diagnosis codes used in our organization that reliably represents that category. Therefore, both lists have 19 conditions each. 3 of the CDMP conditions exceeded a prevalence of 10%, and 11 conditions had a prevalence of less than 1%. For the Fontaine list, 4 conditions exceeded a prevalence of 10%, and another 4 conditions had a prevalence of less than 1%. For MM2+, the standardized prevalence rate was 21.9% for the CDMP list and 25.9% for the Fontaine list. For MM3+, it's 12% for the CDMP and 17.2% for the Fontaine. Notice that the crude prevalence rate tend to be lower than the standardized prevalence rates. And notice that the Fontaine list tend to be higher than the CDMP list. And also the MM3+ list tend to be lower than the MM2+ list. For objective 3, irrespective of the multimorbidity list used, older patients had a higher prevalence rate of multimorbidity compared to the younger patients. For gender and ethnicity, there were no difference between the 2 genders and among the 3 main ethnic groups in Singapore. Using both lists, we found that the most common diets for all the ethnic and gender groups for those aged 45 years and above were hyperlipidemia and hypertension and diabetes. The most common triad was hyperlipidemia, hypertension, and diabetes. What are the implications of the findings from the prevalence study? For the policy and decision makers, we should look at crude prevalence rates as they were the true reflection of the burden of multimorbidity on the ground. For the primary care clinicians and educators, they should work together to create clinical practice guidelines for patients with the commonest combinations of conditions instead of relying on the current single disease guidelines. For the researchers, a very practical and urgent need is to research on the accuracy, the availability, and reliability of clinicians' coding of chronic conditions in the patient's notes. And lastly, basic scientists can look at the connection between different single conditions to explore the reason for co-occurrence at the molecular or genetic level. Before going on to the second study next, I would like to remind everyone that the first study looked at patients with multimorbidity and patients without multimorbidity to determine the prevalence. For the second study, I'm interested in patients with multimorbidity only. Within this group of patients, there are different levels of multimorbidity. This is a systematic review of instruments used to measure the different levels of multimorbidity. I will refer to this study as the systematic review. There were 4 objectives in the systematic review. The first was to provide a list of instruments for measuring the level of multimorbidity. The second was to report advantages and disadvantages of using each instrument. The third was to provide details of the data sources required to use these instruments. And lastly, to compile a list of corresponding instruments for the 3 essential core outcomes: mental health, mortality, and quality of life. The method section. The search strategy included 3 electronic databases and also the Journal of Comorbidity. We selected articles that included community-dwelling adults, had at least one specified outcome variable, and were full-text articles from January 2010 to August 2018. We excluded articles that obtained data exclusively from hospitals or institutions, registered patients with a prerequisite condition, and articles that were not written in English. For the assessment of risk of bias, we used a modified Newcastle-Ottawa scale. It was decided at the start that a meta-analysis would not be performed. The protocol of the systematic review was published in Prospero in September. The results of the systematic review are as follows. The Prisma flow diagram showed that 9,122 records were originally found, but only 74 articles were selected at the end. The 74 articles represented 67 unique studies. 47 studies were found to have a low risk of bias. We found 117 instruments in all the 67 studies, of which 33 of them were unique. For the first objective, we listed the 33 unique instruments into 4 categories. Under count of individual conditions, disease count was the most frequently used instrument. Under organ or system-based approaches, counting of conditions was based on the organs involved or the body systems involved. 3 instruments were listed. The third category was weighted indices, whereby each condition was given different weights based on the specific outcome. There were 17 weighted indices found, and we listed the commonest 3 here. The last category was a miscellaneous collection of other instruments, further divided into 3 subcategories: case mix, pharmaceutical base, as well as clinical judgment. Objective 2 was to list the advantages and disadvantages of each instrument. The advantage of using disease count was its simplicity and requirement of minimal resources. However, it was conceptually inappropriate because it does not take into account the severity of conditions. Furthermore, it forces interpretation of an ordinal scale into a linear one. The advantages of the weighted indices were that they allow adaptation and recalibration. For example, the Charlson Comorbidity Index was developed originally using mortality as an outcome. The instrument has been used successfully on many other different outcomes since. The disadvantage is that for use at the different contexts, the instrument requires validation to ensure that the original weights make sense, or they would need to be recalibrated. An example of the case mix category is the resource utilization band that has been used widely in America with very good results. However, the software is proprietary and the license is expensive. Drug count is the commonest instrument used under the category of pharmaceutical-based instruments. Like disease count, it is easy to use and requires minimal resources. However, not all conditions require medication. Objective 3 looked at the data sources of each instrument. Generally, the sources were from medical records, from patient self-reports, from administrative databases, from insurance claims, or from judgment of clinicians. The last objective was to list the corresponding instruments used for the 3 essential core outcomes for multimorbidity research. There were more instruments used to measure mortality and less for mental health and quality of life. Disease count was the only instrument that was used to measure all the 3 different outcomes. What are the implications of the findings from the systematic review? Only 10 out of the 17 core outcomes for multimorbidity were reported. This showed that intervention studies of multimorbidity were few, and many of those outcomes did not report patient-reported outcomes. The ideal instrument for measuring the level of multimorbidity is elusive. Ideally, an instrument should be able to measure different outcomes by altering the weight of different conditions, for example, a multiple scoring instrument. Further work would be needed to identify the correct combinations of conditions depending on the prevalence and severity impact of each condition for this multiple scoring instrument. Future research for multimorbidity measuring instruments seem to point towards using prognostic models with weighted indices that include social, psychological, and emotional factors in the model. We have now come to the last study, which was a cross-sectional study on the association of the level of multimorbidity with depression, anxiety, and quality of life. I refer to this study as MDEC. There were 4 objectives in this study again. The first was to determine the association between the different levels of multimorbidity with depression, anxiety, and quality of life. The second was to describe the prevalence of depression, anxiety, and the average score of quality of life. The third was to determine the factors associated with these 3 outcomes. And finally, to determine the concordance rate between self-reported conditions by patients and medical conditions recorded in their notes. The setting of this study was Hougang Polyclinic, where I practice. This is a 3-story building where we see up to 1,200 patients daily. We selected patients 21 years and older who had currently 3 chronic conditions. Remember, these 3 conditions were the commonest triad found in the Prevalence study, the very first study. Interviewer-administered questionnaires were conducted using an iPad. The 3 outcome variables were depression, measured using PHQ-9, anxiety, measured using GAD-7, and EQ-5D has 2 components measuring quality of life. The first one is the utility index, and the other one is the visual analog scale. All these instruments were validated in Singapore. There were 14 independent variables. 4 of them were measures of the level of multimorbidity. Statistical analysis was done using SPSS. A p-value of less than 0.05 was considered statistically significant. The results of the MDEC study are as follows. We randomly selected 1,800 patients from a pool of 11,000 eligible patients in Hougang Polyclinic. The total number of recruited patients was 932, giving a response rate of 68.2%. For objective 1, we looked for the association between 4 different types of measurement of the level of multimorbidity. The first was chronic disease control. The second was disease count based on patient self-report. The third was also another disease count, but this time based on the electronic medical record. And the last was chronic medication count. A high number of self-reported disease count was associated with a higher depression score. A higher number of self-reported disease count was associated with a higher anxiety score, but a higher number of EMR disease count was associated with a lower anxiety score. Suboptimal control of all 3 conditions was associated with a better quality of life compared to optimal control of all 3 conditions using the utility index. A higher number of self-reported disease count was associated with a poorer quality of life. A higher number of medication count was associated with a poorer quality of life using the visual analog scale. The uniqueness and novelty of this study was that the 4 different instruments for the 3 different outcomes showed different results, highlighting the multi-dimensional state and complexity of multimorbidity. This slide shows the prevalence rates of depression and anxiety symptoms and the average score of the quality of life. We compared the results to other Singaporean studies. The prevalence rates of depressive and anxiety symptoms were higher than the general population. The average score of the EQ-5D was similar to those with chronic diseases. The average score of the EQ-5D using the VAS was better than patients with diabetes. Objective 3 looked at the association of the social demographic factors with the 3 outcomes again. Those who were not married was associated with a higher score of depression compared to those who were married. There were no factors associated with anxiety. For health-related quality of life, using the utility index, the older age group was associated with a poorer quality of life compared to those who were younger. Those with more education reported poorer quality of life when compared to those with no formal education. Those who stayed in private housing reported higher quality of life compared to those who stayed in public housing. and those with a higher body mass index was associated with a lower quality of life than those with lower BMI. For health-related quality of life using VAS, again, those with formal education reported poorer quality of life than those with no formal education. The group who did not disclose their income reported poorer quality of life than those who reported the lowest income. The last objective was looking at the concordance of self-reported conditions and those found in electronic medical records. Only the condition stroke showed substantial agreement with a concordance rate kappa of 0.61. The other concordance was slight to moderate. The clinical implications of our findings were as follows. The outcome quality of life showed some interesting associations. First of all, instead of education being positively associated with quality of life, the opposite happened. This could be due to a comparison effect where a higher education level raised the expectation of a better quality of life and led to poorer life satisfaction. Secondly, the results for utility index and VAS for quality of life were different, indicating the different domains of the construct of quality of life. The different instruments for measuring the level of multimorbidity also showed interesting findings. For example, those with suboptimal disease control reported better quality of life than those who had optimal control of their chronic conditions. We postulated that a poorer quality of life was a result of the treatment burden imposed on patients when they work hard to keep all the three conditions optimally controlled. Conversely, those patients who chose not to be restrained by the treatment regimes resulting in suboptimal control experienced a better quality of life. Patients who self-reported more medical conditions were associated with poorer quality of life, but patients who had more medical conditions recorded in their notes were associated with a better quality of life. As such, medical conditions that were self-reported and medical conditions that are recorded in the notes by the doctors were conceptually quite different. Thirdly, the poor concordance between self-reports and electronic medical records highlighted the different agendas of patients and family physicians. Until this is sorted out, self-report of medical conditions should be used instead of electronic medical records as it is more patient-centered. We have now come to the conclusion. I will use the last two slides to synthesize the results from the three studies. In essence, the dissertation has helped to clarify some gaps in the concept of multimorbidity. First of all, the definition. I propose that all future multimorbidity research should clearly state all the 5 components, and my recommendations are: Fontaine's list should be used as it is conceptually more suitable for the primary care population and more practical. The number of conditions should be 20 instead of 19. Chronic musculoskeletal conditions resulting in pain should be captured, but is currently not in our Singapore system. Until such time when the medical reports truly reflect what patients are concerned about the data sources, the data sources should be from patients themselves. MM3+ is preferred as it identifies a smaller number of patients with higher needs compared to MM2+. The reference population should be on community-dwelling adults where the index conditions are not useful. The setting of general population or primary care should be clearly stated, as the prevalence rates can be very different. Finally, different age groups should be clearly stated, as prevalence rates of multimorbidity increases with age. Secondly is on the clarity of measuring multimorbidity. The purpose of each measurement should be clearly stated. There are generally 3 purposes of measurements in clinical practice and research of multimorbidity. For diagnosis measurement, one discriminates between those with multimorbidity and no multimorbidity. For evaluation measurements, one evaluates whether the intervention used for management of multimorbidity was better or not better compared with usual care. For predictive measurement, one predicts the outcomes of different levels of multimorbidity. In my dissertation, I've touched on discriminative measurement in the prevalence study and the predictive measurement in the MDEC study. I'm next going to talk about the 3 future directions on the topic of multimorbidity. Future multimorbidity research should involve patients and should be transparent in the methodology, definition, and reporting. For clinical practice, care is better when it recognizes what patients' defined problems were, rather than focusing only on what the diagnoses are. The way we deliver care will have to be revamped in the way we teach caregiving in the undergraduate and postgraduate programs, and also in our daily practice. Family physicians should start to work on multimorbidity guidelines for managing this common phenomenon in primary care. I propose to use a unifying framework to look at multimorbidity. Just like the Russian dolls, where each one is connected to the other, I believe there is a common underlying physiological disease process or processes that may be at play. This underlying process affects the whole individual across the atom, the molecule, the cell, the organ, the systems, and the body. A chronic condition develops as a result of something that's gone wrong in any of these parts that are interconnected to each other. Individuals with multimorbidity will have multiple single conditions leading to a whole, and then interacting with other wholes, such as the environment, which also contains multiple parts, society with its multiple components, and even other concepts like frailty. Using this unifying framework allows both clinicians and scientists to view an individual with multimorbidity as both a whole and as a part of the greater scheme of life. And we must train ourselves to see that and to remember to see that. Otherwise, any research and management of multimorbidity will be piecemeal and meaningless in the grand scheme of things. I thank you for staying to the end of this talk. Please do contact me if you have any questions or would like to collaborate with me on future multimorbidity research. You're most welcome to come and visit me on the sunny island of Singapore. Thank you. Thank you.
Thank you, Dr. Lee. Well done. We have time for two questions, as long as Dr. Lee doesn't take too long in his answers. We started a little late, so we'll continue for another minute or two. Are there questions from the audience, but not from the examiners? Dr. Brown.
Thank you very much. That was just fabulous. It's always fascinating me in terms of the concept of the chicken and the egg. You know, does the depression follow because of the multimorbidity, or is the depression happen? You know, are they more susceptible to multi-morbid conditions because of the depression? I'm just curious what your thinking is about that.
Thank you, Dr. Brown. I don't think there's a real answer to it. And my research has not been able to answer because it was more a cross-sectional study and we're just talking about association. But I believe, just like the chicken and egg, it's the chicken and egg. We probably will never ever be able to find the conditions that are just so interconnected that we can't define what comes first and what comes later. Yeah.
I agree. I mean, that's sort of the dilemma that I feel around it as well.
Thank you.
Thank you. The second question? Leslie Meredith.
Were you surprised that the EMR and the self-reported didn't come up with the same count?
Thank you, Leslie. Yes, I'm very surprised, and because of the finding, I've upset a lot of the people in my department because they have been going around asking questions or getting notes, and they was like, what have you found? Can you prove this is right? So after this, I'm just going to go on to something else where I'm going to prove or disprove that this is right by doing a better organized study. And because it affects how people can conduct multimorbidity studies, especially in the community, are there reports of what they say the truth, or is what the doctors that have written down the truth? But what I realized with a lot of the reading is that how EMR has evolved has become a monster by itself, and it's been serving so many masters, and whether collecting the information of chronic conditions from the EMR is the most accurate, I'm starting to have doubts. Yeah.
Thank you very much for attending this PhD lecture. Thank you to Dr. Lee for a scintillating series of 3 studies. And we're going to move on to another room where the examination will take place. And thank you for coming.
Thank you, Dr. Sue. Thank you, everyone.